Now that we finished absorption, we need to check out what happens as a next story in our general principle of pharmacokinetic, which is distribution of the drug into tissues. There are several key points of distribution, but before we even look at the slide on the computer, remember that to distribute you will still need to cross membranes. So everything we've said previously, whether it would be about pH, pK, solubility, concentration gradient, are absolutely applicable to distribution also. So at this point in the syllabus, all we want to review are the parameters that are really unique to distribution. First, a definition. And the definition of distribution is all the processes whereby the drug will leave systemic circulation and get into organs and tissues. Now, first point to think about for distribution. If you need to leave the blood vessel, well, you have to worry about protein binding. Protein binding, particularly to albumin, will prevent the bound drug from leaving the vasculature, basically. As we saw in our general diffusion equation, the drug is too large when it's bound to a protein to leave the vasculature. So only the free fraction of that drug can distribute. This is shown to you as point number 2 and as a little chemical equation showing you that drug, which is active, which is free, when it's bound to a protein, becomes a complex that is inactive because of its lack of distribution. It will never be able to reach receptors. We're quite lucky that this binding is absolutely reversible. And if it's reversible, really there is a certain fraction of the drug that is free and a certain fraction that remains bound. And as the free drug leaves the blood vessel and gets into tissue, then to keep the fraction constant, more of the protein-bound drug is released, becomes free, and in turn gets into the tissue. It's not irreversible binding. First problem that we might think about: what if I don't have enough proteins, or what if I have too many proteins in my bloodstream? Well, we can rest assured that most often protein concentrations in our bloodstream are far in excess to drug concentration. Look, if I represent this on the whiteboard, you could literally represent protein concentration, such as albumin, as a big block like this, and your drug concentration as a small amount like that. Notice you could decrease albumin level to very low amount. There would still be plenty of room, plenty of proteins available to allow that drug to bind to albumin. So it would be really unusual to think that there would be such a powerful hypoalbuminemia in a patient that now I would have more free drug. Of course, it could happen potentially in very severe cases, but I'm afraid you'd long be dead of having no albumin in your body before you would have a difference in the fraction of the free drug. What is much more relevant at this level is the point 3 on your syllabus, so on your slide on the screen, which is, imagine that there's another drug out there, and that drug wants to bind at exactly the same spot as the red drug. Well, now you realize that irrespective of the amount of albumin in the blood, you have an issue of competition for binding sites on the albumin molecule. When this happens, one of these two drugs is going to win for binding. It's based on the affinity of the drug for the binding. And as one drug binds to the site, it will displace the other drug. In doing so, that could very much change the free fraction of the drug that is displaced, which would then in turn allow that free fraction to distribute better and potentially cause toxicity. There are many classical examples of this in the clinical world. I'll give you one, for instance. A classic drug, maybe let's put it in red here, is warfarin. You know warfarin, an anticoagulant. And as anticoagulants go, well, we always want to keep their effect within a very narrow margin. Too little anticoagulant, you're going to be clotting everywhere, have a stroke or have a heart attack. Mind you, you don't need to buy drugs anymore if that's the case. And too much of that drug, unfortunately, will make your blood too thin, and now you're going to have a hemorrhagic stroke or maybe start bleeding and having issues with this. Warfarin happens to be 98% bound. If it's 98% bound to plasma proteins such as albumin, we understand then that there's only 2% of that drug that is free. And 2% free, this is the fraction of warfarin that will cause all of the clinical effect of anticoagulation. What would happen if I gave another drug that would compete with warfarin? It would quickly increase the free fraction of warfarin. Well, let's try an example. Imagine I gave a drug that would displace 2% of warfarin binding. What is 2%? It's so small, isn't it? But if I displace 2% of warfarin binding, what is now going to be my free fraction? Now my free fraction will be those 2% displaced plus the normal 2%. I will have doubled my free fraction of warfarin. And believe me, with double the free fraction of warfarin, that patient will start bleeding. That's why protein binding and competition between drugs for protein binding will be very relevant for drugs that are highly protein bound, such as warfarin for the exam. Other issues with protein binding and competition could have to do with endogenous compounds. Think of a neonate and bilirubin. You remember bilirubin is a byproduct of metabolism of heme and is very lipid soluble, highly protein bound on albumin on its way to a liver to be conjugated for elimination. Unfortunately, during that protein binding, if any other drugs are available in the body and try and bind to albumin, they may displace bilirubin and eventually enhance the free bilirubin fraction in maybe a neonate. If that was to happen, that free bilirubin would cause kernicterus and irreversible neurological damage in that baby. So don't worry too much about levels of proteins. Worry more about competition of drugs and protein binding. There are special barriers to distribution. Two key barriers to distribution are the placental and blood-brain barrier. Placental and blood-brain barriers are pretty relevant to prevent drugs from reaching the baby in utero or from reaching the CNS and have toxicity. If sometimes they're great because we have no interest in having the drug to reach those compartments in our body, sometimes they become a big hindrance, particularly the blood-brain barrier. Imagine you want an anxiolytic effect or an antidepressant effect. Maybe you simply want a high because you've heard so much general principles, you're starting to be brain dead. The fact is, your drug will have to cross the blood-brain barrier unless you take a syringe and plug the drug directly in your brain. Normally we can't do that, it bends the needle. So thanks to this, how are you going to be able to cross the blood-brain barrier? First key point, you need lipid solubility. Second key point, you'll need a very small drug. And the more lipid soluble and the smaller the drug will be, the more likely it will go across those barriers. Well, how important would this be? It'll be instrumental in our CNS drug section. Certainly, all CNS drugs must have in common to be lipid soluble and to be small if they are to reach the CNS. And when it comes to placental barrier, there the key issue is pregnancy. More often than not, we do not want drugs administered to the pregnant mother to reach the baby. So there, rather, you would have to choose drugs that are more water soluble and that are large. That's always where the trouble lies. You know that most drugs we administer are not water soluble. They're not water soluble because we want them to distribute in mom. And if we want them to distribute well in mom, then the only major choice we'll do in pregnancy is very often to choose a drug that is very highly protein bound. Indeed, the higher the protein binding, the lesser the free fraction, and therefore the less likely we're going to get some drug crossing placental barrier and going into the baby. A great example here would not be CNS drugs, but potentially choices such as imagine hyperthyroidism in pregnancy. You have two major drugs to choose from: propylthiouracil, we call PTU, or methimazole. And let me tell you that PTU is very highly protein bound, methimazole is not. Which one would you choose then in your pregnancy and hyperthyroidism? Hopefully you would have chosen PTU, the highly protein bound drug, so that like this you have no risk of causing anti-thyroid effect in the baby. Otherwise your baby at birth would have hypothyroidism. Remember the issues of thyroid hormone and their requirement for appropriate neurological development. You might end up with cretinism in that baby if the drug would cross the placental barrier. I'll give you another example if you want a relevance. Imagine mom has seizures. There you have to use CNS drugs for seizures. Therefore, by definition, those are lipid soluble and small drugs. Which anti-seizure medication is more likely relevant if you're pregnant? Well, the one that will be highly protein bound, which generally is phenobarbital, barbiturate. So think of these barriers as being both good and troublesome, depending on whether you want to cross these barriers or not. Final point then about distribution is how can I represent distribution as a pharmacokinetic parameter we call VD for volume of distribution, and what are its relationship to regular parameters such as the dose administered and those blood concentration we achieve. Let's look at the board again 1 minute. When we look at the parameter of volume of distribution, we're going to look at our first equation of pharmacokinetic. And your best bet for equations in pharmacokinetic is to try and understand them. The better you understand them, the more likely you can use them. Often on the exam, you don't really need to calculate things. You know, they're not testing us if we're good in math. But they sure will want you to understand the relationship between parameters. The whole story starts at the level of a concentration. If I call a concentration C, think of units of concentrations. I don't know, I could think of things like milligrams per ml. That's a great unit. What are milligrams? Milligrams are amount. They are mass. And the amount of drug you give to a patient, you call that the dose. mLs, those are units of volume. And the volume in which the dose of drug will get to is what we call the volume of distribution. So basically the concept behind this is that a concentration is always an amount per volume. And the amount of drug given is called a dose. The volume in which it goes to is called the volume of distribution. Thereby, the first equation of pharmacokinetic simply states that concentration is dose divided by volume of distribution. That's the first point I would show you here. And when you think of this, then we have one little problem. And that one little problem we have is, as a function of time, concentration keeps on changing. So if I want people, when they give a dose of drug, to calculate for me a volume of distribution, I'm going to have to make sure that everyone reads the concentration at the same time point. Well, mathematically, what will be taken is what we call C0. And C0 is the concentration at time 0. This is a pure mathematical parameter that's calculated by a computer that's extrapolated from those plasma level curves. Since you would guess as much as I would, typical of mathematics, there is no physical correlate at time 0. If you just administered the drug, you don't have a blood concentration yet. But if you know that concentration 0 from a computer, and you know the amount of drug you've given, can you calculate the volume of distribution for me? I'm sure then you can come up with the equation you have in your syllabus, which is that volume of distribution would be equal to dose divided by C0. And that's the one that is given in on your screen right now. Same thing. What are key points to pull out from this equation? Well, I think one of the first points I would like you to really remember that we're going to use often is the relationship between a dose and the concentration. Notice that when you look at a dose and a concentration, they are directly proportional. As you increase a dose, you increase a blood concentration. For instance, if I double the dose, I would expect that my blood concentration would also double. That's providing VD remains constant. Conversely, I would then contrast the blood concentration and the drug's volumes of distribution. And the equation tells us that volume of distribution and concentration in the blood are inversely related. What we can say out of this is that the higher blood concentration, the lower the volume of distribution. Vice versa. The lower blood concentration, the higher its volume of distribution. Those are key relationships. Now, what is truly a volume of distribution physically? Volume of distribution really is a mathematical number. Since C0 is extrapolated, VD could literally be anything. You might find volumes of distribution of drugs reaching thousands of liters. Surely it doesn't mean you are dealing with treating a whale or something of that nature that weighs several tons. Obviously, no humans would have VDs of several thousands of liters, yet drugs do. It's an abstract number. All you can say is if VD is very high, blood concentration are low. essentially telling you, my drug is not in the blood when VD is high, my drug is in tissues. It does not tell you what type of tissue, but the higher the VD, the more likely the drug has distributed well. Contrast, when VD is low, a sign that concentration in the blood is very high. You can have yet a very important point to pull out. What could have kept the drug in the bloodstream? Hopefully you're thinking things like water solubility that would have ionized the drug. Certainly protein binding would trap the drug inside the blood vessel. To the extent that we'll say that drugs that have low VD and therefore stay very high as blood concentration tend to be drugs that are extensively protein bound. So looking at the size of a VD most often gives you an idea of how well the drug has left or stayed in the bloodstream. In the margin in your syllabus, you will see that we give you some of the physiological volumes. Now those physiological volumes are unusual for the common drugs. They're relevant for physio, showing you that the volume of distribution of chemicals that would go in total body water would be a VD of 40 to 42 liters. Now such chemicals would allow a physiologist to figure out how much total body water there might be in a patient. For us on the exam for pharmacology, what it might mean is if a board question was presenting to you a drug X as being a drug that is distributed in total body water, then indirectly what they're telling you is use a VD of 40 liters for that drug X, since that's roughly the total body water volume of a 70 kilogram patient. Now, still looking at these equations, what do you think would happen to the volume of distribution of a drug if I was displacing protein binding in the bloodstream? You remember that if I compete for drug binding to plasma protein like albumin, I enhance the free fraction. You further remember that the free fraction is what tends to distribute. That means competition for protein binding in the plasma will increase the volume of distribution of a drug. A final point about distribution is what we refer to as redistribution. Now, what are we talking about here? We're talking generally about highly lipid soluble drugs such as central nervous system type of drugs. When we look at CNS drugs, they're required to be lipid soluble to cross the blood-brain barrier. And as we give them, we would expect them to very rapidly get into the CNS. If you look at the diagram called redistribution, you see the blood-brain barrier to the left, and therefore the CNS to the left of the figure. In the middle of the figure, you see the bloodstream, where drug D would be initially, after the phase of absorption. And to the right of the diagram, you see the fat tissue. Highly lipid-soluble drugs like CNS drugs will very rapidly reach the brain. This is arrow number 1, and cause a CNS effect. By the same token, that highly lipid-soluble drug will also nicely go into adipose tissue. And this is shown as drug D to the far right, slowly getting into fat tissue. Key issues with this. The effect of the drug in the CNS will be very quick, but will be also very short-lived, since the drug through equilibrium will leave the CNS and redistribute in adipose tissue. Problem clinically with this: if you were trying to use the drug only once, well, you know you have a very short-acting drug in the CNS, the more lipid-soluble it is. No problem there. But what if you wanted a long duration of action? What if you wanted a chronic management of something like pain, anxiety, depression? Then you would have to give multiple doses of that drug. When the drug's effect in the brain is gone, the question to answer is the drug actually gone out of the body? In reality, if the drug is very lipid soluble, we may not see the CNS effect anymore because of redistribution in adipose, and that drug might be trapped and stored in the adipose tissue. So a great deal of that first dose of drug is still present in the patient's body, even though there is no more CNS effect. What do you think would happen then upon second dosing of that patient? If you give a second dose of that highly lipid soluble drug, it will add on to whatever drug is still in circulation inside that patient's body. And now you would have larger amount, therefore larger blood concentration, and more likely bigger effect, longer duration of action of your second dose of lipid-soluble drug. All this because of redistribution in adipose tissue. Now you imagine, give a third dose, a fourth dose. The more you give of that drug, the more you're going to pile up that drug into the body, and the longer the duration of action of those subsequent doses. It's not going to go on forever. Eventually you will saturate the adipose tissue and reach a steady state. It does mean, though, that we should never apprehend the effect of a drug that is lipid soluble based on a single dose. We should always wait until we reach steady state after several doses in order to see if yes or no the dosing is adequate for that patient. Redistribution allows drug to accumulate and allow subsequent doses to have a longer duration of action. We finished our points of absorption, distribution,